Bogan, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 1 of this 4-part CMEO snack series detailing highlights from the SLEEP 2021 meeting. Today's episode is titled Breakthroughs in the Management of Idiopathic Hypersomnia, The Future is Now. This CMEO snack series is supported by an educational grant from Jazz Pharmaceuticals Incorporated and is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Again, I'm Richard Bogan, president of Bogan Sleep Consultants, LLC, and medical officer of SleepMed Incorporated, now BioSerenity. I am also the associate clinical professor at the University of South Carolina School of Medicine in Columbia, South Carolina, and associate clinical professor at the Medical University of South Carolina in Charleston, South Carolina. I'm especially pleased today to be joined by Yves Dauvier, professor of neurology and physiology at the University of Montpellier and director of the Sleep-Wake Disorder Center, Department of Neurology at the Guy de Chauliac Hospital in Montpellier, France.
Hi, Rick.
To frame today's episode, let's start by reviewing our learning objective, which is to assess the clinical significance of trial results of emerging therapies for idiopathic hypersomnia. Yves, to date, there are no FDA-approved medications for idiopathic hypersomnia. How is treatment typically approached and welcome?
Yes, you're right. Idiopathic hypersomnia is a central hypersomnolence disorder with major symptoms: excessive daytime sleepiness, prolonged nighttime sleep, and sleep inertia, and associated with decreased quality of life. And currently, there is no approved treatment for IH, and we all often use alerting agents approved to treat EDS in narcolepsy, and rarely we use sodium oxybate and clarithromycin.
Yeah, thank you. My patients tell me it's almost like taking a sleeping pill in the daytime. They never really feel awake, and they sleep long times. So among the important highlights from the SLEEP 2021 meeting were new data on lower sodium oxybate for the management of idiopathic hypersomnia. Lower sodium oxybate may soon be the first and only FDA-approved treatment for idiopathic hypersomnia. Yves, you played a critical role in some of these studies. Can you explain the study design?
Yes, the study design is complex. We include adult patients with primary diagnosis of IH according to International Classification of Sleep Disorder. And we did include IH patients with and without long sleep time. Participants could be either treatment naive or taking medication for the treatment of IH, including sodium oxybate, alerting agent, or both. Participants taking sodium oxybate at study entry initiated LXB at the same dose and regimen during the first 2 weeks. Participants not taking sodium oxybate at study entry initiated LXB either once or twice nightly. All participants then enter in an open-label titration period study for 12 weeks to optimize efficacy and tolerability. And then participants enter in a 2-week stable dose period and then were randomized 1-to-1 to continue taking LXB or to take placebo for 2 weeks during this double-blind randomized withdrawal period. And at the end, participants completed the double-blind with an open-label extension study for 24 weeks. Finally, 154 participants were enrolled to take at least 1 dose of LXB, and 115 subjects take at least 1 dose during the double-blind study period. So at the end, 56 patients were treated with LXB and 59 with placebo.
Yeah, it's interesting. It's a very nice study design from a maintenance of effect trial, so we get a chance to titrate them to effective dose, stabilize, and then randomize them blinded. And then, of course, how are you doing? And we look at a number of different endpoints. How sleepy are you? How is your idiopathic hypersomnia doing? What do you think globally, and what do we think as investigators globally? So Yves, will you go over those endpoints for us?
Yes, so the primary endpoints was the Epworth Sleepiness Scale, and 2 major secondary endpoints were IHSS. I will come back on this scale in a minute, and also the PGI. So the primary efficacy endpoint was the change on ESS from the end of the stable dose periods to the end of the double-blind randomized withdrawal period. And mean Epworth Sleepiness Scale score improved with LXB treatment during the titration period and were maintained during the stable dose period. The mean ESS score was around 16 at the beginning of the study and 6 only at the end of the stable dose period. And during the double-blind randomized withdrawal period, ESS score remains stable in participants that continue LXB and worsen in participants randomized to placebo, with, for sure, significant differences between groups. Then for the secondary endpoint, there is the Idiopathic Hypersomnia Severity Scale. And you are probably not familiar with this scale. We developed this scale a few years ago. ISSS is a 14-item self-report validated measure to assess the severity, the frequency of the key symptoms of IH. Again, daytime sleepiness, prolonged nighttime sleep, and sleep inertia, and the consequences on daily life. The maximum score is 50, and higher score mean a more severe disorder. And as you can see on the slide, there is a mean ISSS score that declined during the titration period and indicated improvement, and this improvement was maintained during the stable dose period. So the mean ISSS is around 30 at baseline and 15 only at the end of the stable dose period. And during the double-blind withdrawal period, there is a worsening in participants randomized to placebo compared to stable for participants randomized to LXB.
Yeah, this is a very nice scale looking at multiple domains in terms of how these individuals feel and how the idiopathic hypersomnia is affecting them. So it was good to see these results. I mean, very positive results from this particular study. And as you know, we're looking at two different abstracts here and looking at this data. But one of the things that we did in the study is we asked the patients globally, how are you doing from baseline once they reach the stable dose and then blinded? And so we asked them to grade that themselves, and then we asked them, we had a clinical global impression, patient global impression. Would you review that data?
Yes, so the PGI, the patient global inventory, and the CGI for the clinical perspective were a key secondary endpoint of this study. And we see that proportion of participants reporting worsening of symptoms at the end of the withdrawal period relative to the end of the stable dose period were this key secondary endpoint. And we do see that the proportion of participants that report this worsening was significantly higher for participants receiving placebo compared to those continuing the LXB, and is 90% compared to 20%, and exactly the same results for the CGI. So yes, we may say that based on this study, PGI, CGI, Epworth Sleepiness Scale, and ISSS were in a good direction for sure with the drugs intake.
Yeah, it's really interesting to see how the CGI and the PGI tracked each other. That was amazing. And then the other thing is that we looked at one of the very difficult symptoms that patients have with idiopathic hypersomnia is hard for them to get up in the morning. They set multiple alarms, have this sort of confusion in the morning. And we had a chance to look at that, sleep inertia. Would you comment on that?
Yes, sleep inertia was assessed as an exploratory endpoint with the vision analog scale from 0 to 100. And we were able to see that, as we did see with the ISSS, there is a key improving of sleep inertia in the morning in participants taking low sodium oxybate compared to those taking placebo. So we can confirm what we did see with ISSS, focusing on just this symptom of sleep inertia, which is really bothersome for a patient with IH.
Very interesting. So Yves, clearly in this study, sodium oxybate, lower sodium oxybate, demonstrated efficacy in reducing the symptoms associated with idiopathic hypersomnia. But what about side effect profile and safety?
Yes, the overall incidence of treatment emergent AEs were around 80%, and common AEs, greater than 5% of participants were important, and those above 10% were nausea, headache, dizziness, anxiety, and vomiting, all expected based on what we do know with sodium oxybate trial. So there is nothing that pop up specifically with the low sodium oxybate in this particular population.
Yves, thank you for a great discussion of these two pivotal abstracts from this research study, looking at the safety and efficacy of lower sodium oxybate in patients with idiopathic hypersomnia. Would you like to make any concluding remarks? What did you take from this study?
Yes, so there is currently, again, no FDA-approved treatment for IH, but we did see here today promising data. And the results of this phase 3 placebo-controlled complex double-blind study design in adult patients with IH demonstrated clinically meaningful effect of LXB on excessive daytime sleepiness, symptom severity of IH based on this scale, and the self-report global impression of change, and finally the sleep inertia based on this vision analog scale. The results were significant in patients with IH with and without long sleep time. Both have been included in, and the overall safety profile were consistent with what we do know with sodium oxybate. So again, very promising data is emerging, and hopefully soon it will be FDA-approved treatment and also EMA-approved treatment, because I'm from Europe, as you know.
Yes. And, and we got to introduce this scale and get familiar with the IHSS scale. So I'm pretty excited about that. So thanks, Yves. Now, wrap up with our SMART goals, that is actions that we hope you can use in your practice. So when making treatment decisions, consider therapy that not only improves symptoms and their severity, but also impact functional outcomes, and incorporate the latest clinical trial evidence into treatment planning for patients with IH. Please visit the Sleep Disorders Hub at cmeoutfitters.com for a wide variety of additional activities and resources on sleep disorders for both healthcare providers and patients. This has been episode 1 of the 4-part CMEO snack series detailing key highlights from the Sleep 2021 meeting. We hope that you'll take advantage of the additional short, focused activities in this series. We will discuss additional highlights on low sodium oxybate in the management of idiopathic hypersomnia, as well as key findings on dosing and titration strategies when managing narcolepsy, and the significance of cardiovascular comorbidity associated with narcolepsy. To collect your credit for today's activity, you can click on the link to complete the evaluation. You will be able to print your certificate from the platform. Yves, again, I would like to thank you for sharing this latest data on idiopathic hypersomnia, as well as the enormous contributions you have made to the field of sleep medicine. Both our colleagues and certainly your patients appreciate all that you have done.
Thanks, Rick. I was pleased to be with you today as well.
And of course, I would like to thank you, our audience, for participating and for providing the best care for your patients. Take good care.